Welcome to Lab 3, Heart Part 2, the continuing saga. So, last lab we talked about the basic anatomy of the heart, how to take heart rate, blood pressure, and so on. This time we're going to talk about EKGs, ECGs, EKGs. So we'll go through all of that. Again, this is just an overview. Again, we would have covered this all in lab. This is a review. So it's not like I'm teaching it to you for the first time. It's just kind of used to help you if you need it. And to kind of speed up the labs by giving you some of the notes. All right, so the heart has its own beat. We had that discussion. The heart has its own beat. It has a conduction system in which the electrical impulse is passed through the heart. Again, having the heart pictures in front of you is helpful for this, so then you can see some of these parts. So the SA node is the pacemaker of the heart. That you can see in the right atrium in the pictures. The signal travels. Remember, the SA node is the pacemaker because it sets the rhythm. Those cells beat faster or go through depolarization faster than any other heart cell, so it sets the pace. That impulse is then passed through the internodal pathway. You cannot see this on the heart model, but you need to know this is part of the order. It then passes to the AV node. AV node between the right atrium and ventricle, so AV, atrioventricular node, that you can see. Again, you can see it inside the right atrium of the heart model. It then travels down the AV bundle, which you cannot see on our heart model, but again, you need to know it's part of the pathway. Then branches to head down the right ventricle through the right bundle branch, and down the left ventricle through the left bundle branch. It then spreads throughout the ventricles through the Purkinje fibers, which you can see on our models. There are those little Y structures that kind of look like antibodies that come off the bundle branches. Now, when your heart beats, when the heart cells are contracting, they are depolarizing and repolarizing, like nerve cells we talked about in AMP1, that there are electrolytes moving, ions moving, and that generates electricity. So when the SA node fires, which causes the cells of the atrium to depolarize or contract, you're going to see that because there's electricity being generated. Then go to the AV node, down the bundle branches through the Purkinje fibers. The ventricles will then depolarize. The cells will shorten, contract, and you will see that. Okay, you will see that on an ECG or EKG because you're getting a change in electricity because you're getting the movement of those ions. Now, an ECG and an EKG, electrocardiogram, ECG, EKG, electrocardiogram, but the cardio is spelled with a K, which is the way it is done in Germany. Now, the EKG, you tend to hear that more because it's a very distinct sound. That K is distinct. There's another part of your body you can measure electricity on, or the electricity it's generating, your brain, and that is called an EEG, an electroencephalogram. EEG and ECG sound very much alike. So EKG is very distinct. So if someone yells to you and you're in the emergency room saving the world, we need an EKG. You're going to hear that very distinct. EEG, ECG sound very much alike. So they're not distinct. So that's why you see EKG used a lot. Oops, scrolled to that way too fast. Okay, so this electricity we can measure in an EKG. We can see the change, the depolarization and repolarization of the heart cells. We can see those with an electrical impulse. Again, when heart cells depolarize, contract, it generates electricity, you're going to see a bump. Okay, so we have the P wave, the QRS complex, which is actually 3 waves. We're going to deal with them as one, and then the T wave is the last wave. So this P wave here, this represents the atrium depolarizing. Okay, depolarizing, again, go back to your nervous system action potential. Okay, action potential. So the atrium cells are depolarizing, they are contracting. You get the movement of ions, we see this little generation of electricity. You get the P wave. Okay, so you can imagine the SA node is firing here. Passes through the atrium, you get that contraction. There's this little segment here where there's no electricity being generated. This is when the impulse is going down from the internodal pathway to the AV node, down through the bundle branches. There's a delay there. what happens here is you're not going to see any generation of electricity. So again, there's not going to be a bump. And I'll come back to this in a second. Then it's going to pass through the Purkinje fibers, the bundle branches, the Purkinje fibers. The ventricular cells are going to depolarize. They're going to depolarize, and you're going to see this QRS complex, which represents ventricular depolarization, time when the ventricles are contracting and moving blood. Why is it so much bigger than the P wave? Go back to your basic anatomy. Which chambers have the most cells? Come up with an answer. The one with the most cells, you're going to get the most generation of electricity, so your QRS, your ventricular depolarization, is going to be much larger than your atrial depolarization. Okay? And then, remember, these have to repolarize, just like neurons did. So the T wave represents ventricular repolarization. We have the movement of the ions back to the resting potential. Okay? Back to the resting potential. So, atrial depolarization, ventricular depolarization, ventricular repolarization. So what is missing that should be happening? And it is happening, you just don't see it. And that is atrial repolarization. That is buried in this QRS complex. So it's very small, but it is buried there. So when the atrium are depolarizing, okay, they depolarize, they repolarize, while the ventricles are depolarizing. Okay? And then here, because the ventricles are so big, it's not buried under anything, you can see the ventricular repolarization. Okay? You can see the ventricular repolarization. Move this down a little bit. So we have some intervals. This PR segment, this PR interval, is the time between the atrial depolarization and ventricular depolarization, which is what I said earlier. So atrial depolarize, then you've got this delay as the signal is passed through the pathway down to the ventricles. This interval and segment, you don't have to know the specific numbers, but if it gets too long, it means that the atrium and the ventricles are not in sync with each other. So there's a normal length of this segment. Atrium depolarized, there's a normal segment where you then expect the ventricles to depolarize. If this gets too long, it means the ventricles and the atrium are not working together, which means the blood flow through here is not going to be as efficient, because we want the atrium to depolarize, contract, move the blood into the ventricles depolarize, contract, and move the blood out. If those are not in sync with each other, then the movement of blood is not going to be efficient. The QT interval from here to here, is the whole process of ventricular systole here. Okay, so that's just another one you need to know. And again, there's a normal segment there. We'll talk about what it looks like when this segment starts to do something. This ST segment does not look right. So some people have asked me, maybe not you guys, but what the hardest classes I ever took. And the hardest class I've ever taken between my bachelor's and master's and classes after that was a EKG class, EKG interpretation, because I just found it very hard. It's a lot to learn. It's not as set in stone as you would like it, but there's amazing things that you can tell. It's amazing how much you can tell about what's going on in the heart by just putting electrodes on a person. So one of the common tests to do is a 12-lead ECG or EKG and a cardiac stress test. And so your parents may have gone through this. You're probably too young, but you may have done this, where they put you on a treadmill, they hook you up to electrodes, and they're looking at several views of your heart. And they put you on a treadmill, and they slowly make it harder. So you suddenly may have to walk up a little hill, and then you do that for 3 minutes, and then the treadmill gets a little bit faster, and maybe the hill gets a little bit steeper. And they look at how your heart responds to that stress, okay, to that stress. So when they set this up, what they will do, just to give you a basic overview, is they will put several electrodes on you. These 6 right here go in specific spots between your rib cages. You don't have to know them, but you have 6 right here. Okay, and this actually is on the side. And then you have 4, 2 up here, and then 2 down below here that they're not showing you. So you have a total of 10 electrodes. But they call it a 12-lead EKG. And that is because with these 10 electrodes, and you kind of got to trust me on this, you get 12 different views of the heart. So you get these different views. So you get a view, V1 is looking at a certain angle, V2. V5 is a very important one because V5 is looking at that left ventricle. So if you have blockages there, that ventricle is not getting sufficient blood flow, you'll see changes there. And they're concerned about that because your left ventricle, again, is the strongest and pumps to your whole body. So if it's not pumping efficiently, your body's going to suffer. But you also have windows, and you got to trust me on this, coming down from this electrode to this electrode, down this way. So again, trust me on this, with 10 electrodes, you get 12 different views of the heart. And so the EKG, the one I showed you up here, is usually the way it looks in V5, okay, in V5. But the EKG, the way the electricity is conducting, is going to look different depending on what window you are looking through. So here's one window, 2, 3, 4. You've got all these different windows, this little segment. Each of these segments is a window. So you have 12 windows looking at the heart from several different angles. This way, not only can you tell if there's an arrhythmia or a problem, or a blockage there where the heart's not getting sufficient blood flow, you can actually get an idea of where it's happening based on what window it happens. So the one we just looked at with this nice PQRST, some windows look like that. But you look over here and notice how it looks almost upside down. That's because of the view, okay, because of the window. Imagine, you've got a room and you put the heart in the middle and you have 12 different windows. If you stand at different windows, the heart's going to look different. That's the same kind of concept, okay? Same kind of concept. So this is looking at all the windows. So this heartbeat is the same heartbeat from this window, from this window, from this window. These are all that same heartbeat, just from different windows, okay? So that is a 12-lead ECG. That's where they can put the electrodes. The one we're going to do is very simple. We're going to put 3 little electrodes on you and look at it. Ours is not you cannot diagnose things from the one we're doing. All you can just do is you can see the basic PQRST, and then you can do a heart rate calculation. I'm not going to ask you to calculate an exact heart rate, but nowadays, the machines that you put people on, it will do the heart rate calculations for you. If you ever get into this field or go into cardiac nursing or some kind of cardiac field, you will have to learn this because sometimes the machines will not give you accurate numbers. But the distance between, this is the top of the R wave, QRS, is the distance between these, okay, is the heart rate. Okay? And each of these boxes has a number, has a value. So if the heart rate is here and then beats again here, that means your heart rate is 300 beats a minute. That's probably way too fast. If there's 2 between it, 150, 3, 100, 4, 75, 60, and so on. To get even more specific than that, each of these little lines between these big lines, it has a value also. So when I took this class, the first thing we had to do is memorize each of the lines here, and the distance between the R waves is what's going to give you your heart rate. Okay, is what's going to give you your heart rate. Again, at some point you may just know the distance between the R waves is going to tell you if they're closer together, the heart rate is faster. If they're farther apart, it is slower. Okay, so what in some of these you should know. Again, we're just going to fill in some blanks here. What has an influence on heart rate? This goes back to some AMP1 stuff. Vagus nerve stimulation, parasympathetic nervous system, remember that, decreases heart rate. Sympathetic nervous system increases. Epinephrine is a neurotransmitter of the sympathetic, so it's going to increase your heart rate. Acetylcholine is a parasympathetic neurotransmitter, so it's going to slow your heart rate down. If you reduce the calcium levels in the blood, we went through this in lecture, but remember the SA node fires faster because it has more calcium coming into it. So if you reduce the calcium levels in the blood, it will decrease the SA node firing and thus decrease heart rate. The last one here is the effect of fever. Fever is going to increase your heart rate, get that blood flowing, move that immune system around. Immune system in your heart, in your blood, okay, move that around the body, help you fight infection. All right, we'll do an analysis there. I'm going to show you some EKG strips, normal, abnormal. The only ones you'll have to identify are the ones I'm showing you, and the only ones I will use on the test are the ones I'm showing you. If they have a name on them, I will obviously take that name off. So here's a normal sinus rhythm. Okay, you get your P, QRS, T, P, QRS, T. Okay, so they're all normal. The distance between them, the heart rate is normal, a normal heart rate. Okay, that's a normal sinus rhythm. A normal sinus rhythm means sinus means the SA node is in charge. Okay, the SA node is in charge. Then we have a sinus tachycardia. Sinus means the SA node is in charge, but the resting heart rate is greater than 100 beats a minute. Okay, it's a resting heart rate. The SA node is still in charge, but the resting heart rate is greater than 100. Is this always a bad thing? No, if it's consistently just above 100. Where it becomes a problem with people is their heart rate suddenly races up to over 100, at 140 beats a minute for no apparent reason. That can be a problem. Okay, that can be a problem. Sinus bradycardia, sinus SA node is still in charge. The resting heart rate is less than 60. Okay, is less than 60. That's not necessarily abnormal. Highly trained aerobic athletes, we've probably talked about this, have stronger, more heart muscles, stronger contraction. They're able to pump more blood out per beat, so it doesn't need to beat as much. So my favorite teacher ever in high school was my math teacher, and he was a cross-country runner, long-distance runner, did marathons. His resting heart rate, like at night, got down to like 46 beats a minute. Okay? His heart was just so strong it didn't need to beat as much. So sinus bradycardia does not always mean abnormality either. Now, if the heart can't beat faster and it can't keep up with the need, then yes, that would be a problem. A cardiac arrhythmia is an abnormal electric heart rhythm. So something is not right. Okay, something is not right. A heart block. There's 3 degrees of heart blocks, and this gets a little confusing, but basically what I want you to know that the P wave and the QRS, the atrium and ventricles are out of sync with each other. So the atrium may be beating completely out of sync with the ventricles. A 1st degree block is not as serious. Okay. 2nd degree, 3rd degree get more serious. And why it makes a difference? Because again, your blood is not moving efficiently. Remember, the goal of this contraction, of depolarizing and contracting, is that we're moving the blood from the atrium to the ventricles and out. Okay? Atrium to ventricles and ventricles out. If that's not in sync, that the amount of blood and the pressure you're exerting to move that blood is not going to be very efficient. Okay, and that obviously is going to cause some problems. Okay, heart fibrillation. Atrial fibrillation is when the atrium are kind of quivering. Okay, they're not sending blood efficiently. They're not contracting efficiently. So you see a bunch of P waves in here, and you kind of can't distinguish the difference between a P wave and a T wave. Okay. Atrial fibrillation is not that uncommon. It can happen because of thyroid issues sometimes, but I've known several people that have atrial fibrillation. They can start to get dizzy, but they can actually still feel okay. Their ventricles are still contracting. They're still moving blood out. The biggest side effect they have from this is that they can actually throw a blood clot because their atrium are not fully emptying. The blood kind of sits there, and if it sits there, if blood doesn't move, it can clot, and then that can go out to their lungs. So a lot of time they are on Coumadin or warfarin, some blood thinners, to try to decrease the clotting. In some cases, if they're constantly in atrial fibrillation, they will actually knock the person out, not with a hammer or anything, but knock them out with anesthetic, and they will actually use a defibrillator. They will stop their heart. A defibrillator, boom, not electrocute, but you send electricity through the heart, stop the heart, and then sometimes the heart rhythm will come back normal. Okay, will come back normal. And other people, sometimes medications. For some people, it's just very hard to control. Okay, it's very hard to control. Premature atrial contractions look like this. They may happen too soon. So here you see kind of a regular heartbeat between these two and these two here, and then boom, you get a premature atrial contraction, which leads to the ventricle contracting. So that's a PAC. Those are not necessarily so uncommon. If they happen once in a while, not a big deal. A premature ventricular contraction is when the ventricle contracts without the signal from the atrium. These are not that uncommon. I used to, in grad school, I used to work in my grad assistantship was teaching people how to run stress tests. And we had young people from, ages of 20 to 25. And so you didn't get to see anything that interesting. But every once in a while, someone would throw a PVC. I've thrown some PVCs. What happens is you might feel a little flutter in your chest, that you could be throwing a PVC. So they happen more when people have caffeine and things like that in their system. Smokers throw more PVCs, but throwing one every once in a while, in this case, you can see they're actually throwing one every couple beats. As long as that does not go on, and as long as they don't throw one PVC after another for several beats. Okay, so this is not necessarily abnormal. It's something you might want to look at. The reason these, like here you just see this really big QRS, these are all coming from the same location in the ventricle. They look the same. These, you see this one weird one that doesn't look like the other ones. That means electrical signals coming from different areas of the ventricle. Ischemia is a lack of blood flow to the myocardium, lack of blood flow because there's blockage in the coronary arteries. So this is the reason a lot of people have a stress test, whether they're getting insurance, whether they're having chest pain, angina with exertion. What they will do before they do something more invasive is they will do a stress test. So let's say at rest, what's going to be normal here is you got this QRS. This S wave is going to come up here, okay, back to normal, and then you get a T wave. That's what you see in a healthy heart, okay, in a healthy heart. At rest, their EKG might be normal, but when you start to put some stress on the heart, let's say there's a blockage there, and not as much blood flow can get in there, what's going to happen is the ventricles are not going to repolarize as well. And so you get what's called this ST segment depression. So what might look normal in a resting EKG, when you start to get them exercising and start to stress the heart, they get what's called ST segment depression. And that can be a sign of possible heart blockage, depending on what window it is in. So you're not going to see ST segment depression possibly in every window, but based on what window they see ST segment depression, again with exercise, can tell them where the blockages probably are. And so let's say you start seeing it, they start working and their heart rate gets up to 120 or 130 as they're walking on a treadmill, and you start to see ST segment depression in V5. That's going to tell you that the blockage is most likely in the vessels that are supplying that left ventricle. From there, they will do something more invasive. They will do something more invasive like an angiogram, where they would inject the artery, okay, inject the arteries of the heart with a dye so they can see if there's a blockage there or not, okay? And if they find a blockage, then they have to decide what to do. So when you're doing stress tests, this is what you're looking for, ST segment depression. Now, in some people, they may have ST segment depression with no heart issues, so that would be like a false positive. Some people might not have ST segment depression and still have a blockage. But again, the advantage of it is it's not invasive. Okay? One more thing. In some people, let's say they can't walk very well, they've got some issues, they can actually do a stress test where the person's lying down and they inject them with something that mimics their sympathetic nervous system. Okay, like it mimics adrenaline. And what would happen is, even though they're lying there, when they inject them with that, their heart rate will go up and kind of mimic them walking on a treadmill. And they can then see this kind of things. They can see ST segment depression in that type of stress test. From the people I've talked to, they would much rather do one walking on a treadmill. Getting injected with that is like having a major anxiety attack where your heart rate goes up. So even though you're not doing anything, your heart is beating really hard. And they said it's just not a very pleasant experience. But that is another way to do a stress test. Myocardial infarction is the technical word for a heart attack. So let's say someone's having the symptoms. Chest pain, okay, pain down the left shoulder, nausea, vomiting, don't feel good. They can hook them up to an EKG relatively quickly. And if they see this ST segment elevation, that can be a sign that they are having an immediate heart attack, an acute heart attack. Again, depending on what window it is, they can determine where that heart attack is occurring, and then they can do something about it. Okay? Now, in women, the symptoms of a heart attack are much more subtle. They're not always as obvious. They also may not show the same EKG response. So they may be having a heart attack. It's more likely in a smaller blood vessel in the heart, so it might not show up on an EKG as much as you would see in a male. Ventricular fibrillation. So let's say a person is having a heart attack. We see what part it is, but the heart attack goes on for an extended period of time or is very severe. The heart muscle will start to die. The signals will start getting screwed up. Someone will go into ventricular fibrillation. Ventricular fibrillation is when the ventricles are pretty much quivering. So there is some electricity traveling through there, but it's not in sync enough to actually move blood. So when someone goes into VFib or ventricular fibrillation, they are usually passed out because no blood flow is not going to the brain because the ventricles are not contracting efficiently. This is not where you want to be. Okay? From here, you would usually use, at this point, you would defibrillate the heart, where you shock the heart. So you've seen that on TV. They tell people to clear, they put the defibrillator on, they boom it with a large amount of electricity. The goal of a defibrillator is to stop the heart. Okay, you don't restart it. It's because it's still working, it's just not working efficiently at all. They stop the heart with the hope that the SA node will take over. Okay? That SA node hopefully will take over and then go back into a normal sinus rhythm. Okay, that is the goal. Let's say that doesn't work though, or let's say the heart attack progresses or something else happens to the heart. Asystole, when there's no systole, which means there's no electricity. That's when you hear in the show, it's going across. There's no electricity being conveyed by the heart. At this point, a defibrillator will not work. Okay, a defibrillator will not work. You have to have some electricity, like ventricular fibrillation, because you have to have something to stop and then restart. If it's already stopped, you can't stop it. It already stopped and a defibrillator will not work. Asystole is not a good thing. Okay, that means there's no electricity. The heart is basically stopped. Okay. One more thing, if they are in asystole, they can give them things like epinephrine, adrenaline to try to get some electricity being generated. They get some electricity being generated, then they can use the defibrillator. Okay, then they can use the defibrillator. So again, the defibrillator, you got to have some electricity. You defibrillate, you stop the heart in the hope that the SA node will take over. All right, so again, for these last things we did here, I will show you a picture. Again, if they have the name attached to them now, they will not. So I will give you these same examples, and you'll have to say what they are. Okay, tell what they are. All right, that is the end of this. Again, this could be helpful for a review or to watch before lab. Okay, over and out.